What we wanted to do is just create more community awareness about hormones. Um, as women, we're all experiencing, hormonal issues at various parts of our life. I actually counseled a couple last night. It was interesting because the husband said undoubtedly, I don't know what my wife goes through. I don't, understand. The pieces related to the changes in hormones, different times of the month, certainly during different times of my wife's life. And she was very much in the perimenopausal period and unfortunately having a fairly turbulent perimenopausal period. And then we go through the changes that are related to menopause and, what are those and what are the effects? And so what I want to do is just really be there for women to help them understand hormones, to make individual decisions, to really get it right for themselves, and to do it in a safe and effective way. And three things I want to really point out about hormones, and you'll hear me say this over and over tonight, but the three things that are so essential about hormones are, the right form. So the bioidenticals are really critical. Hormones are like a lock and key in the body. They actually help organ systems communicate. We do a lot of nutrition in our practice. We do stress management, we do health and wellness pieces, but I tell everybody that regardless of getting all those other things right, so if you have no stress and you sleep well and you're eating well and all those things are right, if you don't have hormonal balance, you still will not have optimal health and wellness. You're not going to feel as good as you can. So addressing hormones really becomes an important key to quality of life. Here we go again. So, creating this awareness becomes really important. Bioidentical, what does that term actually mean? It means that, some people call it natural. Well, what it means is that the hormones that you would choose to put in your body are actually indistinguishable from the hormones that you made when your body was cycling on its own. And that's important because, for instance, various people want to use soy or yam and so on and so forth, and it's close, but it's not close enough to the bioidenticals because those things are actually used in the lab to create these bioidentical hormones like are used in the pharmacy, but the actual molecule, the actual precursor of soy or yam that's being used to create the bioidentical is not the actual key that will fit in that lock. And so if you really begin to think about hormones like a lock and a key, you've got to have that key just right for the lock, and if you don't, you're not going to open that door and make the things happen that you want to. So, this may be a little challenging with the slides. So this is what I just said. So, bioidentical hormones or biochemically identical hormones are basically hormones that are created in the lab. They're designed to have the exact molecular structure as the hormones that are produced in your body. So key number one is using bioidentical hormones. What's nice about compounding pharmacies, what's different than what you get with, for instance, a pre-done hormone, it may actually be bioidentical, but it's done through a pharmaceutical company, is it's going to be a certain strength, right? And so in that situation, they're expecting basically you to fit the hormone as opposed to the hormone fitting you. Does that make sense? So when you get bioidenticals through a compounding pharmacy, you're actually able to get the strength and the balance that's just right for you. You're literally customizing this for you, and that becomes very, very important. There's various ways to give hormones. There's reasons to do it one way versus the other. For instance, if a woman has high cholesterol, I may actually choose to do oral estrogen. Some women feel better on a transdermal cream. Other people like ready tabs. Some women travel all the time, so they don't want to use creams because they don't want to put them on their carry-on because they can't get it through security. So determining the type of administration of the hormones is really nice, and that is something that certainly the compounding pharmacies allow you to do, and that's really part of the customization process again. I want to go through a slide in just a minute that's going to talk about symptoms and diseases related to hormones. But one of the questions is that we ask is are these symptoms and these diseases of aging just really hormonal decline? And it's an interesting question because if they really are part of an anti-aging and a disease preventative model, that certainly is a very different conceptual than why we originally gave women hormones. Because we originally gave women hormones because they complained of hot flashes and night sweats, right? And then we gave these drugs that we called hormones, called Premarin and Provera, to control symptoms. They weren't really hormones, they were drugs. We had all of the issues related to the Women's Health Initiative study that came out because there were side effects of drugs, just like there always are with medications. And so really using, again, the right hormones in the right way. When women come in and they're concerned about the studies and whether or not hormones are really healthy, I always encourage them to think about what their body is like in their teens and 20s and 30s when they're actually making a lot of their own natural bioidentical hormones. And certainly these things that we heard about with the Women's Health Initiative study, stroke risk, heart disease risk, breast cancer, those things are not prevalent in that age group, despite the fact that your hormones are actually the highest. But again, those are your own natural hormones in balance, designed to do what the body actually intended them to do. So, again, during perimenopause and menopause, the issue is that the reproductive hormones begin to decline, and depending on how they decline and what declines, it's going to be a different picture for each woman. And I think that's important too. Some women have the classic hot flashes and night sweats and sleep disturbances. Other women, the most significant thing that they actually experience is cognitive decline. And I have some women that literally say, I was doing fine until menopause, and literally now I can barely put a sentence together. I can't remember things. It's really affecting my work or my quality of life. Other women really complain of joint issues. I hear that actually fairly frequently. And sometimes those women are not experiencing hot flashes or night sweats, but they're wondering, why all of a sudden do I have all this joint pain that bothers me and takes away from my quality of life and my ability to be normally active. So, we really want to look at the individual pieces for women. And let's go back, because these probably are not going to come up, and again, I'll send these slides to you. But again, the classic things that we think about are what? Hot flashes, night sweats, vaginal dryness, aging changes, right? Skin becomes dry, decrease in kind of sexual enjoyment. And I think those things fall more in the symptom category of low estrogen. But in the disease category, we actually have things like high cholesterol, right? Osteoporosis. There's science now on Alzheimer's disease and decline in hormones. Weight gain, it's interesting. If you have high estrogen or low estrogen, you'll have weight gain. Of course, if you have weight gain, then you're going to be more predisposed to syndrome X, hyperinsulinism, weight gain, diabetic changes, that sort of thing. So we really want to think about both symptoms and actually also diseases that are related to the change in hormones. It's interesting to me because, some women never have hormonal balance. So we may be thinking about, okay, so really hormones are something that women deal with postmenopausally or maybe perimenopausally, but I actually see women in my practice that from the onset of menses, they never have normal hormonal cycles. And so what that looks like for them is maybe 2 weeks out of the month where, because they're not making enough progesterone specifically, typically they'll have a tremendous amount of premenstrual symptoms that really detract from their quality of life. So don't think about hormones as just something that happens, and changes occur postmenopausally. You really want to think about it through all ages of life. Many of you may have children, teenagers. I always say one of God's little jokes is that usually we're going through menopause, when our daughters are beginning to have the onset of their hormones. So it's kind of this, you know, hormonal nightmare crisis that goes on in our household. But again, especially if you have a daughter that's not beginning to cycle with normal hormonal balance, it can really be a real issue in terms of quality of life. So looking at this curve, you know, if you have a 28-day cycle, what happens is you get this peak of estrogen in the beginning with a small bump in the end. So the red line is the estrogen curve, and the blue line is the progesterone curve. So this has to come up and balance the estrogen that you're making. And if it doesn't do that, you're going to have excess estrogen symptoms, which basically looks like premenstrual stuff. So you're irritable, you're bloated, you're having breast tenderness. So this is kind of in even the young woman where you can have these issues. So number two of the keys to hormones. So number one was bioidentical, right? The right form, the right key that fits the lock. The second key is going to be the right level. And so when I measure hormone levels on a woman, it's really important that you're getting this estrogen on day 12 and you're getting this progesterone on day 21, because what you're looking for is these peaks. You're looking to see, is this woman able to accomplish the kind of balance that's going to give her quality of life? And what I see a lot is blood work that comes in with an estrogen and progesterone level drawn on the same day, right? So they haven't really evaluated this, and most of these women, when they got their levels drawn, they have no idea where they were in their cycle. You know, so there's not, we need to be scientific in terms of measuring things. What you're going to hear typically from really actually most OBGYNs is, because the hormones change, right, because they fluctuate throughout the cycle, we don't measure them because they're changing all the time. Well, that's true, but you have to know where they are in the cycle, and you have to know what the balance is. And so I'm really listening as I'm taking a history from somebody about, do you know when you ovulate? Because sometimes this curve may move up or back depending on the individual. So really sitting with them and determining when they create their estrogen peak and their progesterone peak becomes really important. You know, and any imbalances here are going to make you feel bad. So here we go with our blank slides. I've really kind of gone through this. A point that I'm going to make in just a minute, and let's go on to progesterone. So progesterone, what does it cause? Well, so progesterone is the balancing hormone for estrogen. So going back to that curve, if you have a lot of estrogen production in the first 2 weeks of your cycle, and you don't have progesterone production in the second 2 weeks to balance that, you're going to have weight gain, fluid retention, bloating, even if you have a normal amount of estrogen, because there has to be the balance. So that can be the postmenopausal woman where her progesterone falls off, you know, first before her estrogen, and her estrogen levels maintain. It can be the perimenopausal woman, or it can be the young person. As you know, we did not give women progesterone if they were getting estrogen, if they didn't have a uterus. And the entire thinking on progesterone administration with estrogen was all about prevention of endometrial cancer, because estrogen creates endometrial growth. If you don't balance that growth and signal the stopping of that growth with progesterone, you'll get uncontrolled growth, and uncontrolled growth is basically cancer. So we were giving synthetic estrogen, Premarin. We saw endometrial cancer. We said, oh my gosh, we need to do something about that. As physicians, drug companies came out with a synthetic progesterone called Provera that prevented endometrial cancer, but it actually had a lot of estrogenic type side effects. And so we saw issues with, you know, again, breast cancer problems, heart disease development, so on and so forth. Because the press has over-categorized, so they call synthetic progesterone, Provera, progesterone, but it's not. And that distinguishing point is really important too, because, you know, for instance, if you gave Provera to a pregnant woman, you would create all sorts of birth defects. On the other hand, if you give natural progesterone to a pregnant woman, especially a woman that has low progesterone, you'll protect her from having a miscarriage, and it's safe and healthy and effective. And sometimes, when we actually measure progesterone levels in the pregnant woman, they're in the thousands, right? So the right hormone is protective and good, whereas synthetic hormones, because they're not really hormones, will have a side effect profile. So, Provera, no. Progesterone, protection against breast cancer, heart disease. I love progesterone for sleep. I love it for a lot of women with perimenopause or menopause are experiencing anxiety, right? So progesterone is very calming. It's good for bone density. It's good for beauty pieces. It's good for hair. There's just a lot of good things about progesterone again. And I think, although some of the negative press was about Premarin, I think many women are even more concerned about progesterone because of the Provera scare, right? And it's really important to me. I tell women I will not give them estrogen without progesterone because I feel so strongly about balancing those hormones in the body, because that's how nature did it. And one of the other keys is that we're never going to do better than nature, right? We can only try to reproduce it as best as possible. So the magic, no symptoms of testosterone. So let's talk about testosterone, because tonight we want to talk about the 3 different hormones that are basically coming from the ovaries. I hope we'll do this again and the PowerPoint will actually work. But I want to also talk about adrenal pieces, right? Because most of us, the adrenal gland is related to stress. Most of us don't get to our 40s and 50s, without stress from, kids and family and life and finances and traffic in Austin and all the different things that we're multitasking, all day long, which women are known for. I want to talk about thyroid because, again, I probably see 2 or 3 new patients each week with thyroid issues who have normal thyroid levels but are still experiencing low thyroid symptoms, and the question always becomes, why, what's going on? Is this just in my head? My doctor tells me I should feel fine, but I don't feel fine. I have symptoms of low thyroid. And, what I find too, as I work with hormones in the practice, is that I'm not ever really in a perfect world just working with reproductive hormones or thyroid or adrenal, because the whole system works together. Everything communicates. Again, hormones are about communicating from one organ to the other, and so it becomes really important to have a whole system balance to actually create quality of life. So symptoms of low testosterone. The biggest thing I see with women with low testosterone is low mood and low energy. And that's why I care about it so much, because I hear that over and over again in the perimenopausal and postmenopausal woman. In addition, it's really important for insulin function, i.e. it's really important for your body composition, it's important for skin and wrinkling prevention, so it really is almost kind of a beauty hormone. It's important for bone density, maintenance of muscle mass. So those are all the kind of symptoms and diseases that can result from low testosterone. I think I mentioned bone density and osteoporosis. And then the icing on the cake, the things that we always think about with testosterone is, of course, sexual enjoyment and sexual interest. I think across the board I see with women there is an improvement, in sexual enjoyment. Sometimes it's significant. Some women with hormonal decline become anorgasmic. They can't have an orgasm anymore. It's extremely frustrating for them. Testosterone alone is not the key. It's really about getting all the hormones balanced. But I really think, again, the sexual enjoyment and sexual interest really become the icing on the cake. I always like to tell women, I think this helps us understand men, and it helps men understand us. But the optimal level of testosterone for a woman, I'm going to compare a man versus a woman with the same lab. So we'll use, for instance, Quest lab. So a woman, we're trying to achieve a level of about 4 to 6. For a man, the level's about 160 to 180. It's vastly different. And so that really explains a lot about, again, kind of what's going on with our brain and the level of sexual interest. And, I find with women, sometimes sexuality, it feels like the sun and the moon and the stars have to be aligned, right? Whereas men, they can be so stressed out and have everything else going on in their life, and they're still going to be sexually interested. It just has to do with this vast difference in the actual levels of testosterone in our body. So we talked a little bit about this. What is the traditional medical solution for perimenopause, menopause, or a lot of premenstrual symptoms, right, in the young individual? Well, we put people on birth control pills, right? So what does that do? Well, it shuts down all hormonal production. We become anovulatory, so we don't ovulate. When we don't ovulate, our estrogen, progesterone, testosterone levels fall, our thyroid levels fall, so that's kind of a different discussion for a different day. But this happens all the time. If you don't cycle regularly, you know, they put you on a birth control pill, you have a cycle, you have bleeding related to the synthetic hormones, and they call that normal, right? As to kind of denote that the bleeding portion is what the normalcy of hormones is related to. And, you know, again, the cyclical nature and the actual hormones themselves are what's so important to us feeling good. And I see 50-year-old women, 60-year-old women that either get put on a birth control pill or they ask, why am I on a birth control pill still at 50 or 60, right? They've just stayed on them forever. Previn and Provera, we've already talked about these things. They're synthetic hormones, they're drugs, they're not bioidentical, they're not the right key for the lock. And then, you know, you all probably know this too. When women are having a lot of symptoms, and I hear this all the time, you know, my doctor just wants to put me on an antidepressant. And what do women say in relationship to the antidepressant? Well, typically what I hear is, well, the symptoms of X, Y, or Z are not so great anymore. You know, I don't feel so anxious or whatever, but I really don't feel so much of anything. You know, I just kind of feel flat, and I just really don't kind of care about anything anymore. So that to me really is not a solution either, and getting the hormones balanced is really what we want to accomplish. So we've talked about the right hormone, we've talked about the right level. So again, hopefully there's a slide in here, and otherwise we can just talk about it. But what happens with labs is that the lab actually has a normal range, right? When you are postmenopausal, that normal range is going to essentially say that you don't have any hormones. And that is what's considered normal postmenopausally. So your doctor may tell you that you're normal postmenopausally when you have no hormones in your body, right? That's an issue, because if you don't have any hormones, you're not going to have any benefit of those hormones. Once you replace hormones, there's even a range. So for instance, with estrogen, typically a woman's going to fall to, you know, maybe less than 15, maybe a level of 25. The goal is 50 to 100. And again, when we look at customizing hormones for women and really getting them to feel good, an important question becomes, you know, what were you like when you were young? You know, were you round and curvy, and, you know, did you have signs and pieces that indicated that you were a high estrogen female, or were you relatively, you know, lean and thin, and you know, you didn't have a lot of these excess estrogen symptoms? The significance there is that I will actually try to get a woman closer to 50 or 100, depending on what she actually looked like in her younger life. And indeed, those women will feel different at, say, a level of 55 versus a level of 95. If she was a high estrogen female and I only get her to 55, she may still have hot flashes and night sweats and symptoms. And if I push that up to 85, 90, all those things will go away. So getting in that normal range becomes really important. And then once again, you know, for instance, in the teens 20 person, the estrogen levels are going to be all the way up to 250. So if you have a woman that's 250 or 350 or 400 and makes a ton of estrogen, you know, and then you look at her progesterone levels, and those levels should be maybe, you know, 20, 28, and she's only making a level of 10, that woman's going to have a lot of symptoms related to estrogen excess, only because there's an imbalance there.
I don't mean to interrupt, but so are you saying that, say, in a young girl who's in the middle of all of this, there is a range that is considered healthy in terms of the balance, and you can look at that and determine?
Yes.
Okay.
So if there's a cycle, I'm drawing hormones at 12 and 21. Estrogen at day 12, progesterone at day 21. So that's going to be the young woman who has a lot of premenstrual symptoms, or it's going to be the perimenopausal woman who's having a lot of perimenopausal symptoms but is still cycling. Once you're no longer cycling, then you no longer have to hit that day 12 and 21, right? Because you've lost those peaks that I basically showed you. You know, so
you can draw any day.
You can draw any day. And the classic definition of menopause is an FSH level over 50, so we'll talk a little bit about FSH in just a minute, and no cycle for a year. Will a lot of women have a lot of different symptoms before they actually hit those benchmarks? Yes, and I think because they can have symptoms for years before they hit those benchmarks. That's why that slide with, you know, oral contraceptive pills, Premarin, Provera, antidepressants, probably the birth control pills and the antidepressants are used most commonly in that population because they really don't know what to do about creating hormonal balance, right? You know, it's they just want to shut everything down, or they want to lessen the person's experience of what's going on with them hormonally, okay? So, balance, we've talked a lot about that. So I'm really looking for that balance. And again, when I started doing hormones, I started doing hormone replacement therapy in year 2000. So I've really done it for a long time. And I did it because, again, even if I nutritionally got patients correct, even if I dealt with lifestyle issues and exercise and everything else, unless I did the hormonal piece, I could not achieve optimal health for them. So it had to really be addressed. I saw so many women that were having so many issues on the synthetic hormones, or they were on birth control pills, or they had been told, you know, just get through this with antidepressants. And it just really wasn't a way for women to live, right? I mean, we really deserve to live with hormonal balance and the benefit of those different things. And so, you know, I've learned so much during that period of time, and you know, I've learned a lot again about, you know, there really is a difference between 50 and 100. When a woman comes in with a lab panel now where she's hit these different benchmarks that I'm talking about, you know, I can really predict with almost 100% certainty that she's going to tell me, I feel good, I feel great, I'm sleeping, I'm not stressed, you know, I'm not struggling with my weight, I have energy, my brain is working, all those different things. And conversely, if her estrogen level is high or her progesterone level is high or low, she's going to tell me the things that are related to that. So it's very objective. It's very straightforward, and there's not really a whole lot of magic. You know, I was jokingly saying, to me, this makes sense and it's logical. Trying to get your PowerPoint working is obviously a lot harder than balancing hormones. You know, what about just coming into, you know, a pharmacy or going to CVS or ordering, again, you know, soy or, you know, progesterone cream or whatever online. I'm not an advocate of that because I just think we could do better. I mean, number one, you're never going to get a prescription strength, right? You're not going to know where your levels are and what you need. You're not going to be able to get those levels measured in a meaningful way to do that replacement. You're not going to get the benefit of knowing my levels are where they need to be for replacement, both to have quality of life and disease prevention, and you're not going to know, do I have the kind of balance that I really need for safety? And, you know, I think we have to care about the safety piece with women. I believe, and I think the studies are going to show this out, that the increased risk of breast cancer that we see in the 40s and 50s woman is really related to the fact that most of the time they maintain estrogen levels for a lot longer than they do progesterone levels. And again, when that progesterone falls off and there's non-controlled stimulation of the breast through estrogen, even natural estrogen, even the estrogen that your own body makes, it can create issues. That's why I care so much too about really helping the perimenopausal woman, because not only is she experiencing quality of life issues, but I think she's actually at risk, right? And I don't want the first thing for that woman to have, you know, coming into the office is breast cancer, you know, as her chief complaint. it's just not a way to do things. So we want to get the hormones right. Nutrition, remember when the whole Angelina Jolie thing happened, and you know, she found out that she was, you know, BRCA positive, and she chose to have a bilateral mastectomy. I actually did the one of the news pieces here, and you know, we do genetic testing in the practice. I want women to know that there's so many factors that play into breast cancer, and there's so many different things that you have to consider, but certainly being your ideal weight becomes very important. Making sure that foods that give you breast protection, so cruciferous vegetables, you know, things with sulfur and methyl groups and so on and so forth in the right amount become very important. And so really that those things should come from food, you know, predominantly. Do we do nutritional supplementation in the practice? Yes. Why? Because people's nutrition is not perfect. But in a perfect world, we wouldn't do any supplementation. It would just all be food. Exercise. I mean, most of you know that exercise protects against breast cancer. And it's one of those things, you know, I tell women that health is kind of like trying to get eggs in your basket. And sometimes it seems a little complicated because there's a bunch of eggs that you have to go get, and most people, you know, carry their basket around through life, and they get a couple eggs in, and then they hit a blip in the road and a couple eggs fall out. You know, well, the thing is, you got to go back and get those eggs back in, and once you get them all in, it's a pretty fantastic place to be, you know, despite our age and despite where we are. But one of those pieces is exercise. And can you really be optimally healthy if you're hormonally balanced and you're eating right, and maybe you're taking appropriate supplementation if you're not moving your body? You really can't. And especially in the 40s and 50-year-old woman, there's particular ways to move your body that are really, really critical for body composition and protection. So we really want to go through those things with women too. If you want to do yoga and you want to do Pilates and things, great. Any movement of your body is fantastic. But there's certain things that I want you to do critically that are really important for breast protection and health. And lifestyle support, you know, and again, you know, we live in such a busy, frenetic world. We're always working on, you know, stress and sleep and balance and all those things that are really important to women too. Oh, fantastic. So here we go. This is what I was talking about. So, you know, if this woman came in and her lab level said 26 for her estrogen, you know, postmenopausally, and the normal range is 50 to 100, you know, postmenopausally, she's 26, which is normal. Her progesterone level is less than 5, which, you know, postmenopausally is normal, right? And her testosterone level is 1.3, which postmenopausally, that's low. She's going to be told she's normal, and she doesn't have any hormones in her body, okay? So normal versus what you really need to feel good is very different. Here we are again on hormone replacement therapy. So I'm shooting for a level of 10 to 20 in a postmenopausal woman, and she may feel different at the lower end versus the upper end. I want a level of 50 to 100 in terms of her estrogen levels, and I want a level of basically 4 to 6 on her testosterone. And I'm adjusting these things based on the individual to actually create balance. And here we are with that cycling woman. So again, I mean, you can see how different your progesterone levels are postmenopausally versus when you're cycling. Postmenopausally versus when you're cycling, right? Postmenopausally versus when you're cycling. And that's why women feel so different. You know, we may do a series for men if we can get enough men in here. They have their own, you know, their own term now called andropause. The difference between men and women is that men's levels fall off slowly. So it's a kind of a more insidious thing that they really don't notice. But when you talk to them, you know, they'll say, well, yeah, my energy and my drive and, you know, my sexual function have, you know, kind of waned, and, you know, the solution is, you know, more coffee and, you know, some Viagra and, you know, so on and so forth. But again, you know, I believe too that men deserve hormonal balance just like women do. And certainly young women with premenstrual symptoms, you know, deserve balance also.
Do they have any other hormones?
They do.
Is that the
They
only
do.
one they have?
Nope. So men, Well, a couple things. So, and women have these things too. So what we want in a man is to be high testosterone, low estrogen. Some men will take testosterone if you administer it to them, and they'll do a lot of estrogen conversion. And so we actually have to kind of biochemically address that and block those pathways. They also have progesterone. We work a lot with melatonin with both men and women for sleep, and because it actually stimulates growth hormone levels, and again, growth hormone is kind of out of the realm of what we want to talk about today. But, men, high testosterone, low estrogen, women, relatively high estrogen, low testosterone creates the actual balance there. But it really is, to me, to think that, we go through our lives and we're doing so many things and taking care of kids and taking care of our spouses and taking care of our jobs and everything else. I mean, we deserve to feel good from 40 and 50 for the rest of our life, right? I mean, we may live half of our life now after 40 or 50. And, the question is always, what will that look like for a woman or a man?